Hi, everybody. My name is Carolyn Dubé. I'm the Executive Director at Fertility Matters Canada. We are the national patient support network here in Canada. I'm thrilled today to be with a good friend of mine and a long-time supporter of FMC and all Canadian fertility patients, Dan Nayot, of the Fertility Partners and also of Future Fertility. So Dan, thank you so much for making the time be with us today. Dan always has really interesting topic, and IVF add-ons is something that we actually do hear about in our support groups, and people have questions about. So I'm really excited to hear your expertise today.
No problem. Thanks for having me, Caroline. I think I might be officially done at the Fertility Matters Canada, but it's like a tattoo, you can't get it off. So
That's right.
I'll always be here to support. I think what you're doing is amazing, and it just keeps getting better. So we're going to do a little mini webinar. I'm hoping it's interactive, so everybody on the other side, don't be shy. Like, plug in with your comments and questions. We'll talk about IVF add-ons. I think this is like stressful to the patient and the physician because everybody wants to make the right decision. Like, everybody has the anxiety that maybe they didn't optimize, and is it worth it and stuff like that. I mean, obviously, we're not going to talk about any particular patient scenario or add-on, but I think just the general. Basically, I'm going to teach you how to select wine from a wine menu, kind of thing.
Awesome.
Okay. So here we go. So we'll do some ground rules. I'm assuming here that the audience is more patients or interested industry folks, but not like AI experts or lab directors or something like that. So I'm going to keep it more general. Again, I'm not going to go too deep in any specific add-on because each one could be a whole lecture on its own. And nothing I'm saying here today should be seen as like, for sure, you should use this add-on. It obviously depends on the scenario. So just use this as like a learning tool and then go speak to your clinical team.
Great.
Okay. Here we go. Okay. So again, we're talking about IVF add-ons, although there's other types of add-ons out there. IVF stands for in vitro fertilization. Again, some of the audience members may have never heard of it. Some may have already been through it. Some are in the middle. But IVF stands for in vitro fertilization. In a very simplified way, there's a few steps to it. Step number one is taking fertility drugs, hormones to stimulate ovaries. What happens then is follicles grow. We, your physicians, are then extracting those eggs out of your follicles. And generally, we add sperm to the egg and we try to support those embryos. And then we generally, one at a time, put those embryos in, or sometimes we test those embryos, or sometimes we freeze them to use them at a later date. But generally, IVF is hormones, eggs extractions, putting sperm and egg together, making embryos, and then transferring embryos. Okay. Caroline, I'll let you sort of stop me if you see questions and stuff like this.
Yeah, okay? I'll jump in. Perfect.
You just jump in. Okay.
I will.
So I think before we evaluate, like, what the heck is this add-on and should I add it, I think we need some like ground rules, some basics. So, in IVF, I would say what we describe as like a success has changed over the years, but now in 2020, I think almost everybody would agree that a single healthy live birth equals success. Here's a controversial comment. So some people would say twins would not be seen success. Maybe we put too many embryos in. And then the other side of the story is, why would that be a bad thing? Two healthy children instead of one. We're struggling with fertility. But the reason we see a singleton is the main is because it minimizes risks. So yes, two healthy babies is amazing, but not every twin's pregnancy ends up that way. So we always want to, the ultimate goal is, how do we get someone a healthy baby as fast, as cheap, and like at least as stress as possible. Okay. I think just a comment on statistics is extremely important. From the consumer or patient side, it's easy to say, add this add-on because it increases things 5%, or, the take-home baby is this percent. So we got to make sure we're talking the same language, okay? So let's talk about all the steps in an IVF cycle. And because this is real life, what we call this attrition. Attrition means you're going to lose people along the way. And so I'm just made up a random scenario, but I think these are reasonable numbers. So let's say you have 100 patients sitting in front of me saying, okay, Dan, we get it. We're committed. We're ready to start IVF. So that's our baseline. That's our denominator. We have 100 patients ready to start. So everybody shows up to the clinic and everybody takes fertility drugs. Let's say 5 of them don't make it all the way to the trigger date because either a follicle didn't grow or they didn't like the symptoms or whatever reason. So we already have lost 5 patients. So now we got 95 days, excited, they got their trigger. 2 days later, we go in there for the egg collection, and let's say 5 of those, for whatever reason, only had a few follicles, and the doctor went in and they say, I'm sorry, there's no eggs in those follicles. And that does happen. So now we're left with 90 patients who are lucky enough to have at least 1 egg. And we're going to put sperm and egg together that day. And the next day we're going to call them. And 5 of them, we have to give them the really horrible news that, like, unfortunately, none of those eggs successfully fertilized. This cycle is done. I'm sorry. The 85 who get at least 1 egg fertilized, so they're sort of still in the game. We watch those embryos, but there's a big drop off from a fertilized egg to a blastocyst. So let's say 50 of them were lucky enough to reach a blastocyst, and that means 35 of them we had to say, like, I'm sorry, we tried our best, but none of those embryos made it to a blastocyst. You should probably follow up with your physician to talk about. So now we have 50 people who have blastocysts, and in this scenario, we're going to assume everybody did genetic testing or chromosome testing, PGTA. I understand that's not always the case, but to simplify the math here. So let's say all 50 decided to test their embryos. Let's say 20 out of 50 had at least 1 normal embryo. So the physician and the doctor and the patient are excited. You've got at least 1 good-looking embryo. This may really work for you. And we put those embryos in. Not every good-looking normal embryo is going to work. So let's say we got 15 out of those 20, which I think is a reasonable statistic to work. Even if we have a big, successful, what we call the BFP, the big fat positive, and that first ultrasound looks great, not all of them are going to make it all the way to the end. And then, so let's say we had, of those 15, 66% or 10 make it to a baby. So then you have so many numbers here. You can add and divide any way you want. The real question is, like, in this scenario, which is a realistic scenario, what is the success rate, right? Well, the patient sitting in front of me saying, will I have a baby or not, wants to know, out of 100 patients in my scenario, am I going to have this baby this cycle? So that would be 10%. Only 10 out of those hundreds made it all the way through. The patients who say, you sometimes hear, 75% live birth rate with a euploid embryo. Okay. I'm not saying that's wrong. That's great. But that assumes you have made it all the way to the euploid embryo. It's not saying when you started, you got a 75% chance. So it's very important that you figure out what the denominator is.
Just
Okay.
to jump in here, for those
Yes.
of you, for those people watching who don't know what a euploid embryo is, what's a euploid embryo?
Good question. I'm going to pass it to you. You're the executive director. So a euploid embryo, I'm just joking around. So a euploid embryo, so we have a blastocyst, which is a day 5 embryo, which is hundreds of cells. We now have the technology, which I'll talk about in a few minutes, where we can biopsy. So we sample a few cells and we analyze it. Now, the thought process is, to be a healthy pregnancy, you need 46 chromosomes. And if that number is off, too little, too many, that's an embryo that might look good, but that's not going to make it all the way through. So a euploid embryo is a tested embryo that's shown to be 46 chromosomes.
Awesome. Thank you for that.
No problem. So essentially what I'm saying is the success rates, you really got to figure out the numerator. So the top number, the final outcome, and the denominator per what? Per people starting, per people who got an egg, per people who tested their embryo and stuff like that.
Okay.
You can make your success rates, again, another controversial topic. You can try to make your success rates as high as possible. One way to do that is to put like a whole bunch of embryos at the same time. So if you put 5 embryos at a time, it's probably a higher chance that it's going to work but obviously there's bad implications that twins, triplets, and bad outcomes and stuff like that. So yes, your success rate per transfer is higher, but I'm not sure that's the best thing to do. Another way to increase your success rates, again, this is a potential way, is to sort of select who can go through IVF. So if you say, listen, I don't think you're going to make it to, you're not going to get more than one egg here, you shouldn't do IVF, you've already pre-selected who gets to go through. Okay.
Got it.
Okay. Okay. So we showed you the diagram of what IVF is in general. Let me show you again in general what happens in the lab. A lot of people who have been through IVF have gone to what we call the collection room. So you're there in stirrups, there's an ultrasound, the doctor's there trying their best to extract as many eggs out of those follicles as possible. And the patient is told, hey, you got 17 eggs or 4 eggs or whatever, but you don't really know what's about to happen behind that window. Okay, so behind the window, can you see my cursor, Carol?
Yep, I can.
Okay, so behind the window, the embryologist gets these little buckets of fluid and starts looking to see if they can find an egg. We're almost sifting through, okay? When the egg comes out, so you need a microscope. You can maybe see with your eye, but you certainly need a microscope to really see it. And this is what it looks like in the microscope. So one thing a lot of people don't know is when it first comes out, eggs look like this. So here's the egg, and there's a lot of supporting cells called the Cumulus cells. So you can imagine if you were trying to say, is this a nice looking egg or not? You'd say, I actually can't see anything. I know there's an egg in there, but I can't tell very much about it. So generally what we do is we sort of, we think the egg extraction is kind of a stressful event. We sort of let those eggs sort of calm down in a controlled environment, incubator for a few hours. And then we go in there and we call it stripping those eggs. So we take those cells out, and then this is the egg that most people have seen pictures of, but that's really only once you've stripped those eggs. Okay. And then you have, I'm assuming someone's going through IVF. We use IVF as a general term, but there's 2 ways to add sperm. IVF, which means in vitro fertilization, which actually means you don't strip the eggs. You just put thousands of sperm around the egg and you sort of let, you put them real close next to each other and you let natural selection see if a sperm will do it. ICSI is the other way, which means intracytoplasmic sperm injection. Like this picture, what you do is you pick a sperm, hopefully, a good looking, fast moving sperm, and you drill it right into the egg. So for ICSI, you have to strip the egg. For IVF, you don't have to strip the egg. Okay, either way, you're adding sperm and now you got to support them. So embryo development are usually done in the incubator. We'll talk about different types of incubators, but essentially, I would say standard of care 2020 is probably to grow to a blastocyst, which is a day 5 or day 6 embryos. So this thing goes from a single cell to 2 cells and 4 cells and 8 cells to hundreds of cells. Once you reach the embryo stage, which you can sort of see down here at 114 hours, this is a nice looking blastocyst. There's pretty much 3 options. Put it in, test it. So this is a picture of somebody biopsying it. So you can see it sucks out a few cells out of the outside of the embryo, or you can freeze it for the future. But that's essentially the basics of what happens in the lab. And this is sort of a 5 or 6 day process. Any questions out there before?
I don't have a question yet. I have a personal question though. When you do the biopsy of the embryo, and you take those few cells, is that what becomes the placenta and that's why it's okay? Like talk to me about why it's okay to take those few cells and that the embryo remains sort of intact and healthy.
So good question. So, back in the day, we used to do these biopsies, let's say on day 3 when there was 8 cells. And then we quickly learned that, taking 1 or 2 cells out of 8 is probably a big proportion of the embryo. Now, one of the most common questions I get is like, so did you just take one of the arms off of a future child? Mm-hmm. And these are sort of, these are uncommitted cells at the moment. They haven't figured out where they're going. So you aren't going to structurally affect the child or something like that. But you made a good comment. Where are we doing this biopsy? If you think of the embryo, there's the outside, which we call it the outer cell mass, and then there's or trophectoderm is the official name. And there's the inside, I don't know if you can see it here so well, which is called the inner cell mass. So the inside becomes the baby, the outside becomes the placenta. So one of the controversies of PGTA, I mean, there's a lot of pros and cons, is are we even sampling the right thing? We're sampling the placenta. Getting self-correct, things like that.
Got it.
Okay,
Thank you for that.
no problem. So I'm gonna keep going here.
Yeah, keep going.
So, all right, IVF add-ons. You know, I think just that term is an interesting term. Add-ons means like you've got your basic and do you want this as well? I mean, I think if it was already part of the like there is so many extra steps we do in the lab, we just don't call it add-ons because the patient isn't involved in the decision and there isn't extra cost to it. I think probably cost is the key part why people call it an add-on, right? But to me, it's kind of like Porter. I don't know who our audience is, but let's say they've been through Porter, at least in the Toronto City Airport. One of the reasons I think everybody loves the Porter experience is, you know, you go down an elevator and you've got this really nice cafeteria, and then you're just shocked to find out it's like all for free. All the coffee, all the Coca-Cola, all the cookies, and you put them in your bag and you think you feel like a VIP, but people don't realize they've already paid for that in their ticket price, right?
Right.
So
the in-flight beverage.
Exactly. So, you know, to me, it's kind of like IVF. There are some people whose IVF costs, you know, pick a number, $20,000, and there is no add-ons. Everything's included in it because the lab thinks that's how we optimize your outcomes. And there are clinics who will say, okay, IVF is $12,000, but if you want this and you want this and you want that. So a lot of it, I think, is psychological.
Wow, that's actually really important that you touch on that, because I don't think that that's a clear, it's not clear, and you do see differences in price from different clinics, different provinces. So thanks for touching on that.
I mean, there's more to price than that, obviously,
for sure.
Location and lab, but the point is sometimes it's considered, you know, the term add-on is because do you want to add, and there's a cost element to it. I think the most important question here is like, does the add-on we're going to be talking about harm the outcome? Well, okay, well, that's a really bigger discussion. Probably you don't want to do that, or you really want to consider the risk benefits. You know, if it doesn't harm, then sometimes it's a cost benefit analysis from a financial point of view, right? So if it doesn't harm and it's free and it may potentially help, I think there's not much to discuss. Most people say, sure, why not? But the bigger discussion is like, you know, let's say this thing costs $500. How much does it really help me and stuff like that? I think, in my point of view, cost should be seen as a risk because, you know, what I tell patients, and I stole this from someone else, is like, you only have so many resources to succeed. Like, the more cycles, the more attempts, the more you try again, the more likely you're going to succeed. But everybody has their limit. Sometimes it's physical, emotional, but a lot of times it's financial. We cannot afford to try again. So sometimes I tell patients, if you can save money here so you can try again, right? Anyway, when you think of add-ons, these are the things you have to think of. Does it harm anything? I would say, as a general rule, probably not. Like, why would a fertility clinic? I mean, no one would want to try to harm. Everyone's trying to succeed here. But I mean, these are things you want to think about in more newer innovations. Is there any evidence and the cost benefit about it? Okay. And you know, the problem with add-ons is it's like, you know, let's say, yes, it's one thing, but what is your scenario? Do you need it and stuff like that? Okay.
Got it.
Okay. Let's talk about just some add-ons. So again, disclosure, I'm not promoting or, you know, pushing you from a certain add-on or not. I won't even be talking about the evidence. I just think you need to know the rationale, like, why are we even talking about this thing?
Yeah, that's really great.
Okay, endometrium. So generally, let's say you're lucky enough, you're one of those lucky ones to have a blastocyst, whether it's tested or not, but you know, eventually you're going to need to do the embryo transfer. Generally, what your physician and team look for is that the uterus structure looks normal, but you know, what patients always hear, like, how thick is your lining kind of thing. Like, oh, it's 6, it's too thin, they're going to cancel it, or it's never going to work. Oh, it's 9, it's amazing, of course it's going to work, which is a nice guideline. It's true that thickness correlates, but it's not so black and white, right? There are some, teams that look more than just thickness, but also pattern. But then we come on to these sort of add-ons. What else can we tell from an endometrium? Either, the whole point is like, make sure the soil is great so that when we put the seed in there, it's going to grow. Okay. So one add-on out there in the market is called the Matrix. It is basically an ultrasound that people get anyways. The idea here is that it's using some form of computer-assisted algorithm to give you a score. And the idea here is to help the patient and the physician decide if this is a good cycle to put the embryo in or not. So it's kind of like a cancel or go for it or tweak something in between. Again, I'm not talking about evidence pro or con, but that's the rationale. The doctor's thinking, okay, yes, we have thickness, but maybe this computer program can give me more insights other than thickness if we should go for it or not.
And so what's the other evidence? Yeah, sorry, I missed that part, Dan. Like, what's the other information you would get from this test that would make an RE say yes, this or this?
Well, I don't have time to go into the evidence of each one of these, but the rationale is that the RE says, listen, generally we wait for the lining to be above, let's say 7 millimeters.
Yep.
Yours is, but maybe the computer can give me more insights other than just thickness.
Okay.
So we are looking for one variable, thickness. We don't know what the computer is looking for, but it's giving us, it's analyzing it on a different variable than just thickness.
Okay.
So patients and doctors say, yeah, if you can tell me, like, the idea here is like, don't waste my embryo if you don't feel good about the soil part.
Got it.
Okay. What's more popular and I think talked about now are things like endometrial biopsy. So I call it invasive because you need a little procedure. I mean, it's a daytime procedure. Any OBGYN RE can do this, but I'm not going to pretend there's no discomfort, but it's quick. But essentially you need to put a catheter in the uterus and you suck out some tissue and you're analyzing it. So it is invasive. It does take time to analyze, but you probably get more information. There are two big tests out there. One is called ERA, Endometrial Receptivity Assay. The idea here is there's this window of implantation. Like if you put this embryo too early, sorry, the door's closed, it's not going to make it. If you put this embryo too late, sorry, the door's closed, it's not going to make it. So there's a specific, that's the concept. Again, I'm not going into the details. Mm-hmm. And the thought process is, yeah, we all know that. And the window of implantation should be, let's say, 6 days after progesterone. And then people say, yeah, that's in general, but maybe not for Caroline and maybe not for Stacy. Like, so this is a more personalized, maybe I don't need 6 days of progesterone. Maybe I need 5, maybe I need 7. Yeah, I'm not commenting on the evidence, but the idea here is personalizing the day you're putting that progesterone in, the day you're putting the transfer in based on number of days of progesterone to sort of try to hit your personalized window of implantation. That's the whole idea. So you do like a mock cycle, you do a biopsy, you get the results and you say, okay, Caroline, for you, next time we're doing it after 7 days, not after 6 days.
And this would happen, like you said, it's a mock cycle that happens. There's no actual transfer happening around the time of this, this procedure. You would wait another cycle and go there.
Sure. So the downsides here is like, it's invasive, but I think you'll be fine. It's time consuming because you got to do a mock cycle. You got to wait for the results. It's expensive. And then does it really help what you're going to do next?
Got it.
The other, what else is becoming more popular, and you'll see it more and more over the months to years, is the idea of like the microbiome or bacterial environment inside the uterus. So a long time ago, we used to think that the uterus was a sterile environment. And now like the pendulum is shifted and we think it's like the opposite of a sterile environment. A good example is like skin's not sterile, vagina is not sterile. So why would the uterus be sterile, right? So, everyone can understand like, things like yeast infection come from like bad bacteria versus good bacteria. So lactobacilli is the most common one. Everybody knows, everybody has heard of like, hey, if you take antibiotics, your vaginal microbiome might be off, you might get a yeast infection. And it's true, it's a common thing. So it's the same idea with the uterus. Maybe there's something there we can't pick up on ultrasound that needs to be addressed or treated. Okay. So these are sort of add-ons. Again, they're add-ons because it takes time and effort and cost.
Got it.
Okay.
Thanks for that.
No problem. So now let's go. So that was outside the lab, assuming we already had an embryo. But let's talk about, maybe I should have done it the reverse way. We got to make an embryo first, right? So first thing we want to do is, so let's say we got the eggs. I mean, there is no proven treatment yet. Like once I have an egg, I can't make an egg better, or no one can yet. Okay. I mean, there are some research, interesting stuff, but let's just assume no one can make the egg better once we get that. A topic of like how to make your eggs the best they can is another topic, but once you have the eggs, your eggs are defined. Okay. Generally speaking, so I'm going to do my own plug-in here, the full disclosure, but generally speaking, there is no egg scoring system. So there is no embryologist in the world, no one who's ever gone through them has ever gone to score on their eggs. Everyone's gone to score on their embryos. You have a 4AA, it looks great. You have a 2BC, I don't feel so good about this. But no one's gone an egg score that says you've got a 7 out of 10 or a 1 out of 10 or something like that, because it doesn't exist. Okay. So there are some add-ons that can give you some insights. Again, I'm not talking about evidence here. So one of them is called the Spindle View. So so here's a picture of an egg here. You can see my cursor again. So this is called dark microscopy or spindle view or Assay, different names for it, but essentially it's like the reverse microscope where you see white, now you see black. And when you do that, you get to see what's called the spindle. The spindle is where the chromosomes are, okay? So it's like packed and ready. They're gonna split once we add that sperm. So we think that gives you like a new interesting way to look at egg. It might be insightful. Again, not talking about the evidence, should you use it, should you not. But the idea when someone hears about Spindle View is like, maybe we will get more information about your eggs or be able to rotate them so that I can put the sperm at the right place. Okay.
Oh, interesting.
The only other egg sort of assessment tool that's out there, that's what me and my team at Future Fertility are working on. So shameless plug here, is called the Violet. And the idea here is, yes, the human eye can see things, but the human eye cannot analyze it. But we created an artificial intelligence image analysis. You know, it looks at pixels and patterns and things like that. And we've already shown that we can, you know, we're superior to embryologists in what we can see in the eggs and predicting it, okay? At the moment, the Violet is only used for egg freezers to figure out what we think will happen to these eggs, but very soon we're gonna apply to all IVF cycles to create almost like an egg score, an egg evaluation, but considered an add-on. Is there a risk? Not really. I mean, you're not touching the egg. It's just a picture image analysis. But is there, like all add-ons, you got to consider what's the point and the downside and stuff like that. Okay. In terms of sperm, again, if you do traditional IVF, you're just putting thousands of sperm, and good luck to those sperm. If you're doing ICSI, you're picking a good-looking sperm and you're putting it in. So there are some sort of add-ons of how to prepare the sperm. So Zymote is just one of many examples of that. But the idea here is it's almost like an obstacle course through like different channels and ions. And, you know, the winners of the race are probably the best sperm. And let me choose among the best sperm. Okay?
Wow, that's so interesting. I've never heard of that one.
It's logical, it's rational. Again, not talking about evidence, but at least you understand the rationale of why we're doing it.
Absolutely.
So the idea here is let's prepare the sperm so the embryologist will only pick about among the winners, kind of thing. Okay. Then there's something called IMSI, which means like, yeah, the microscope can see a nice looking, fast moving sperm. And we assume that it means it's a good sperm. We don't know that. Just because someone is like tall, dark, and handsome doesn't mean he doesn't have high blood pressure, but it's a pretty good indicator. So IMSI is saying, you know what if we can see more? Like, let's get an even more powerful microscope, and then we can see these like finite details in the sperm, and then maybe we can select it better because maybe we're picking the wrong sperm. So these are sort of add-ons. The rationale is like, maybe we'll see better and maybe we'll select better. Yeah.
Great. So Dan, if someone was looking for, you know, if one of these add-ons was interesting to them, how does are they offered in all clinics or labs, or how would a patient kind of figure out if this was something that was right for them?
So this goes back to 2 slides ago. It's very clinic dependent. So there are some clinics who say like, this is going to be a 1 hour confusing conversation between the doctor and the patient, and you're going to add stress and steal time that could be used elsewhere. Just, hey, doctors and embryologists, the experts, just do whatever you think you can do to optimize outcomes. And here's your IVF cost.
Great.
Okay.
Great.
There are some clinics who say, you know what, none of these are critical, and is it fair for us to add all this extra cost to something, because it does cost the clinic to buy all these things. Is it fair for us to pass that cost to the patient when they never really ordered it, right?
Right.
So some clinics sort of say, this is the basics of for sure what you need, and then have a discussion with your doctor about that. So I think it's clinic. I mean, you'll find out based on the clinic you're going to be at.
And some of these things that happen inside the lab, like you said, are things that the patient wouldn't even know are actually happening.
Right. Sometimes they do, and sometimes they don't.
Okay.
Okay, so we talked about eggs, we talked about sperm, so now we put them together and we're growing embryos. So the traditional incubator is like this big black box. It's dark, it's controlled with like light exposure and chemicals and pH and whatnot. And once a day, we quickly open it and we take a look and see what we see, and we sort of jot it down, we put it back. That's the traditional incubators used around the world. And probably, I don't know, a decade now, someone clever said, you know what, maybe we don't have to take those embryos out at all. Why don't we put kind of like an iPhone on top of it, and we just take a picture every few minutes? Very logical. And it creates this like time lapse. You don't want a 5-day video. No one's going to watch that. But you do like a time lapse video condensed into, you know, a few minutes. And maybe that's going to give you more information. But maybe just the fact that you're not touching that embryo and exposing it to the environment is going to help. But so that's called the time lapse incubator. Again, this is a perfect example. Some labs, that's just the incubator they use because they think that's going to give you the best success rates, and you have no clue. And some labs say, listen, here's the traditional incubator. We had to pay, you know, a whole lot of money to get this special incubator in. If you want to use it, there's an add-on. So that, I would say the time-lapse incubator is one of those add-ons that you hear about all the time.
Mm-hmm.
Okay. Another one, which I think is probably common news now, are things like, should we test these embryos? I would say that's considered an add-on because the price point is pretty high. I haven't seen a clinic yet that offers it automatically, because, you know, some people always say, why am I paying $25,000 for an IVF cycle? No, thanks. I'll just pay 15, and I don't want you to test my embryos, right? I think I'll be fine, or eventually I'm going to get there, or something like that. So PGTA, I think everyone's heard many lectures on it, but again, it's just biopsying the embryos and analyzing it. It's another common add-on people talk about. And maybe like a 2-minute, you know, version on that, the pros and cons. So let's start with cons. So cons is cost. It's expensive. You know, different price, different clinics, but generally it's expensive. Con is takes time. You now have to biopsy, you have to analyze, you have to freeze, you have to wait for the results. Con is there's always the potential to harm the embryo. You know, you are doing something mechanical, but of course these are experts doing it, and the damage rate is pretty low, but not zero. The con is like, you know, we all want normal embryo equals baby, but still, even if you have a normal embryo, that doesn't guarantee a success, right? It probably increases our odds. So the one other big con, which is a big controversy in our field, is like, what if that sample doesn't represent the embryo? What if I tossed out that embryo, but it could have worked? It could have self-corrected. Maybe that was the garbage cells that they analyze. So there are people who will argue that PGTA throws away embryos, and therefore, by definition, you've lowered your chance of success because those embryos could have worked.
Got it.
The pro side is most studies are pretty consistent that it will get you to the finish line faster. You have to do less transfers because you're hopefully not putting any abnormals. And if you get pregnant, the miscarriage rates are lower. So the way I sort of, again, it really depends on the scenario, but I think the simplified version of, or the messaging I would give patients is like, if your mindset is like efficiency, like how do I get to that baby ASAP? Then we say, all right, well, let's make embryos and let's screen them and then put them in one at a time. The reverse is like, if you have one IVF cycle in you, that's just what you're committed to financially, physically, socially, like emotionally, then I sort of tell patients, well, then if you only have one cycle in you, I don't think I would throw any embryos away. Just get to the end of them, and if it didn't work, we know it didn't work, but why discard them? That's just my messaging. It's complicated messaging, and it's maybe too simplified, but anyways, any questions about that?
No, that's great.
Okay, so in terms of AI, embryologists already have a grading system and they watch how it grows. So, their job is to select the best embryo first. But of course, it's not a perfect science. There are some companies now using artificial intelligence to say, maybe we can pick it better than the embryologist. These 3 embryos look similar, but I think this one should be picked. So, applying AI to embryos is another thing that sort of you will see in the future. Anyways, maybe I'll stop it there because it might be too content heavy. And then maybe I'll take questions.
Yeah, for sure. Okay, so we do have one question that's come in on Facebook here, or a couple of them now. Why would you take a day 3 fresh embryo versus waiting to day 5? So I'm assuming that this means why would you choose to transfer a day 3 versus a day 5 embryo, which I know is a little bit outside the add-ons, but it's a good question to look at.
Yeah, so I think you can see my screen here. So a day 3 embryo kind of looks like, let's say this, like 8 cells. So it goes like this. We talked about attrition. So not every follicle is going to have an egg. Not every egg is going to have a fertilized egg. Not every fertilized egg can make it to day 3. Not every day 3 is going to make it to day 5. Not every day 5 is going to, okay. If you have 10 embryos on day 3, I mean, we don't know which one's going. There's a lot more to choose from. It's going to be hard to pick the one. If you let them grow to day 5 and you say, oh, look, of the 10, only 4 really have the potential, it's easier to select from. So that's one thing. So we know that the chance for a day 3 versus a chance to a day 5 is lower. So which makes sense because you're earlier on in the journey, right? Mm-hmm. So the earlier you pick it, the less screening, the less potential it has. Okay.
Right. So a day 3, the survival rate, is that what you're saying? The survival rate of a day 3 versus the survival rate, or the chance of a implantation and a live birth? Is that what you're?
But only because you don't know what it is.
Right. Okay.
So I think I'm going to flip the question. I'm going to answer like a politician. Let's say you have one day 3 embryo. Mm-hmm. So the question is, should you put it in now? Should you wait 2 days because everyone's talking about this day 5 and put it in, or should, some people are talking about freezing, or should you wait to day 5, freeze it in and put it in later? Okay. The thought process is maybe the uterus is a better incubator than our lab incubators. So, hey, put that embryo in as soon as possible because maybe it would have worked in the uterus and it wouldn't have worked in the lab. I say maybe 20 years ago, that's probably correct. We weren't as good, but nowadays where it's pretty standard of care, they have done studies. If you have a single day 3, put it in or wait till day 5, and the outcomes are the same. As in, if this is a good embryo, it's going to take where you put it on day 3 or you put it on day 5. So sometimes it's psychology. So sometimes it's the patient saying, give me a chance, put it in the uterus. I don't want to see that embryo not work in the lab and then always wonder what could happen. I think the psychology of the doctor, I won't speak for all doctors, I'll speak for me. I sort of try to push everyone to a day 5 unless they get to decide, but I think I would recommend it because if it's an embryo that would have worked, we'll get to see it go great and we'll put it in. And if it stopped growing, I now have information for you why in 2 weeks that pregnancy test is negative. Because otherwise,
really important messaging.
Because otherwise we're sitting in front of each other and say, how come I didn't get pregnant? I'll say, I don't know. We put it on day 3. I can't tell too much on day 3 about that embryo.
Very interesting.
But not that's one of those things that not every patient, not every doctor will come up with the same solution. Mm-hmm. Or say, yeah.
Got it. Okay, I have another question. I can see the obvious benefits of ICSI over IVF, but now that I know that with ICSI, we need to strip the egg of its cumulus cells, is the stripping a stressful action for the egg?
Oh, amazing question. Give that person like a gold star.
That's it.
So everything we do here, you're like, they always say like 2 REIs, 3 opinions.
Mhm.
So, some of us say like, maybe you need the Cumulus cells as support. So maybe stripping them isn't good. Some people say, well, the Cumulus cells essentially slough off anyways, and maybe that has like bad toxins. So maybe removing them early is good. In reality, when, the question is, should you do ICSI or IVF? A 1-hour lecture and debate. Maybe we'll just focus on what people kind of agree on. I think people kind of agree on, if you have really poor sperm quality, so let's say you needed surgery in the testicle to get the sperm, then generally we like to pick a good looking sperm and drill it through. Or a lot of times, if the egg has been frozen and we think the shell has hardened and maybe the properties have changed, we want to put it through. But there are clinics who think ICSI should not be used unless for sure you have to. And there are some people who think ICSI should be used on everybody because maybe you're increasing something. I'll tell you my own personal bias. As you've already seen, I like to have information to give back to the patient. So when I look at this kind of egg, I have no clue, I have no feedback for you. When I look at this kind of egg, although there's no egg scoring, I have something to provide you. Like if, for example, all your eggs look like crescent moons instead of circles, that might be informative information, right?
Got it. Great, thank you for that. Okay, another question from Facebook. I know they say an embryo that is frozen has a chance of working, but what are the realistic odds of being successful with a low-grade C embryo? I know that's challenging for you because that's a you don't know all the details.
Yeah, that's not too much IVF add-on. It's more clinic specific, but I can talk about that. So, when we talk about embryo grading, it's visual. What do they look like on the day of? I always tell patients, like, I have no idea what embryo I was or you were. But, it's also dynamic. We have all seen embryos look not great when we froze them, and then we found they look great. We actually did a study on that, and like the embryos that didn't look great at freezing and look great on thawing, for whatever reason, they bounce back, and now it's a dynamic thing. The pregnancy rates are pretty high. The problem is you have no clue until you come and thaw them, right? So,
Yep.
But that's a good example of success rate. So one thing is, like, some labs will have a criteria and say, we will not freeze an embryo unless it's a certain grading. Now, they're not trying to be mean. They're trying to say, like, are we putting this patient in more distress by keeping an embryo frozen that has very low potential? The counter side is like, did you throw an embryo that could have worked? Maybe it didn't look great, but it's going to work. You have to remember, most things in this IVF world is like a spectrum. So we all seen people say, hey, you got a 5% chance, and then they show us their baby 9 months later, right? So I don't think you should throw away a 2C, but I think you should be counseled appropriately. I think part of the distress in IVF, it's a very distressful thing, but the ones where you see even extra distress is nobody prepared them. You can tell their expectations, somebody did not prepare their expectations.
Right.
Yeah.
And that's a really good point. I think that you hit on, is preparing. And it's part of the work that we try to do with Fertility Matters to help patients, prepare their expectations for what this can look like. And we can only do so much from this patient support side, but it's important, I think, to have those conversations and to advocate as a patient for yourself to set yourself up for success or a potential, unsuccessful transfer or cycle, by having those conversations and clear expectations.
I can tell you that the trends I see from my side of the table is, like, for example, everybody's excited for that first embryo transfer. You worked so hard, hopes are high. And if it works, it's amazing. And if it doesn't work, you see this huge drop because there's this feeling that we just picked the best embryo. And if the best didn't work, the rest is futile. And I was like, somebody didn't prepare that patient to be like, we actually don't select it that well. And it's all subjective, and each one is an independent event, and things like that. Because sometimes we see patients not come back after the first transfer. We as physicians say, why didn't they come back? There's more embryos here. It's because in their mind, somebody didn't prepare them properly.
That's really good to well, it's hard to hear, sad to hear on the patient's perspective, but good to hear that. And I know that you're really focused on patient-centered care. So,
but it's important because the patients who come back are the ones who eventually succeed.
Absolutely. And my personal story is very similar to that. My first IVF cycle was unsuccessful with a very good graded embryo, and it did not work. And I know that deflation and like, how do you move forward if that was the best one? And then transferred a not so great rated embryo, and that was my first success. So, but it's hard, and it's good to share these types of stories and help set the expectations for patients. So, thanks for addressing that. Okay, so do you think, are there any sort of add-ons that you see that aren't commonly used yet? Are there any IVF add-ons that aren't commonly used yet that you think should sort of be more industry standard, or that more patients should be asking about?
Well, it's interesting because a patient can only be offered an add-on that the clinic provides, right? So sometimes people come to my clinic and they say, hey, I'd like to try this, Z. And I said, okay, even if we want to try it, we just don't offer it at our clinic. So we can't do it. So, but I mean, of course, I'm a big believer in innovation. I think why I got into this field, it's rapidly moving. Even now, minus 5 years ago, it looks very different. But I mean, again, full disclosure, I believe AI will be a critical piece to this. What I go around preaching is like transparency. I think that's really important for the whole journey for a patient. Like, for example, let's say you went through IVF and you got 12 eggs, and at the end of the 5 days, you're one of the unlucky ones that had no blastocyst. Unfortunately, that happened. The gut reaction from the patient is like, who left my embryos in the sun? Right. Was it, obviously I have good eggs and good sperm, and what's going on? And was it the junior embryologist on that day? Like, people want, and they deserve transparency. So something like a time lapse, when you can show them like, no, like we really did get 12 eggs and we really did see that they stopped growing. It doesn't change the outcome, but it's like, there's a trust in there. You understand it.
Yeah. Yeah, that makes sense.
There are sort of like reports sometimes we see, it's a very emotional field. So like, again, when I see a patient and I estimate what I think their chance of success is, there are a few variables go in my head. There are some like online free calculators, and they should be somewhere similar to what I'm saying. So if I'm sitting in front of a patient, I was like, oh, of course you should do this again. 95% chance you're going to succeed. And you go online and you see 10%, something's off here, right? Like either I know something you don't know, or the reverse. So I think transparency is going to be a critical part, and you see it everywhere. Like, even like patient labeling. Everybody has the same fear. The doctors and the patients, like, what if the samples mix up? How do you know it's my sperm? How do you know it's my embryo? And we do lots of things. So we double check. We get people to co-sign it, but like, still, that's already moved from paper to now electronic. Now we have these sort of like electronic tracking. Every time someone did something to your embryo, and that gives you that security. That kind of stuff is going to penetrate the whole field.
Yeah. Where do you see, so another 5 years from now, where do you see these add-ons or AI or these types of things? And what do you think is sort of the next step? What are we going to be seeing? And in 5 years, where do you see the industry?
I think the world is flat kind of theory. Like everybody's getting better in terms, like we're all sharing information. It's strange because there's competitor IVF clinics, but the weird part is like every time we all come up with interesting stuff, we share it. So I think things sort of get to flatten out, which is great. So the labs are getting better and better. I think access to care will increase. For example, like there's some people who can't get to IVF because they live too far north. Just logistically, that's going to change with like telemedicine. There are people who are waiting 11 months to get a second opinion. That's going to change because we're going to make things faster. But yeah, I definitely think AI is the future because you can see things that the human can't see, and I think that's going to create insights into like what to do next.
That's awesome. And then hopefully success rates, pregnancy rates, live birth rates will continue to increase. I mean, it's still such a young field in medicine, really. It's just 40 some odd years old. So in the world of medicine, that's in its infancy.
It's crazy. I mean, if you think about it, like the first, like 10 years ago, who would have thought a uterus transplant would have been possible? That sounds like sci-fi, but now there's dozens of cases.
It's amazing.
Yeah.
Wow. Well, Dan, thank you for this. This was, every time I do one of these, I'm always learning, and I work in the industry and I feel like I know lots of stuff, but thanks for this, because I did learn a few things today. So I know that our viewers also did. So I appreciate you. I appreciate Fertility Partners for allowing you to spend an hour with us today. Thank you to everybody who has joined us live today. And if you're watching this on our replay, thanks for tuning in. If you need to reach out to Dan, he is on Instagram at, I forget your Instagram handle.
I forget it too. Be somewhere here.
At Dr. Dan Nayat on, that's Twitter, and then on Instagram at Future Fertility AI. Sorry, I had a hard time reading it. So if you have questions for Dan, reach out to him there. I appreciate everything. And just a reminder, Fertility Matters Canada is a national Canadian charity. If you're able to donate to our charity, please find us on our website, fertilitymatters.ca. Any donation is appreciated. Thanks, Dan. We'll be in touch soon.
Thank you guys. Have a great day.
Bye.
Bye-bye.